Why don't we get started right on time? Good morning, everyone. For those of you who don't know me, I'm Albert G. I'm one of the faculty here in the Department of Orthopedic Surgery. I'm stepping in for Dr. Chansky today because he's away. But it's my pleasure to introduce the Grand Round speakers this morning. This month's Grand Rounds is going to be run by Doctors Jerry Huang, who is a professor in our department in hand and upper extremity, and Gabrielle Bui, Dr. Gabrielle Bui, who's one of our fourth-year residents, who I believe is interested in hand and upper extremity surgery as well and going into that subspecialty area. So I'm very excited to have them give Grand Rounds this morning, and their topic will be on forearm non-unions, old school and new school. So I believe, Dr. Bui, you're going to start us off here. And thank you, everybody, for attending.
Thank you, Dr. G, for that introduction. Give me 1 second to share my screen. I'm Gabrielle Bui, and today I'll be discussing forearm malunions, old school and new school. I do not have any relevant disclosures. Here is an outline of my talk, and then Dr. Huang will be taking over and discussing 3D custom guides and case presentations. Starting off with a bit of background, forearm fractures are common in the pediatric population and occur in 1 in 100 children, with a peak incidence between the ages of 5 and 14. And while most children continue to remodel their deformities, there is an incidence of radiographic malunion ranging from 2.4 to 13.2%, and 0.5% of those go on to a symptomatic malunion. Forearm fractures are significantly less common in adults, with an incidence in 1 in 10,000 people per year. And while there are numerous complications associated with diaphyseal forearm fractures, for the purposes of this talk, I'll be focusing on malunion, which is estimated to occur in 5% of adults with diaphyseal forearm fractures. We'll start off with a bit of basic anatomy. The radius has a physiologic bow, and it rotates along a stationary ulna during pronation and supination. And the PRUJ and the DRUJ are the only points of contact between the radius and ulna. And then biomechanically, the longitudinal axis of the forearm bisects the center of the radial head and the distal ulnar fovea. Proximally, the radial notch of the ulna articulates with the medial side of the radial head to form the PRUJ, and the annular ligament stabilizes the joint during rotation. And this stabilization allows the PRUJ to work in conjunction with the DRUJ during pronation and supination. At the DRUJ, the head of the ulna articulates with the sigmoid notch of the radius, and strong stabilizing ligaments that are part of the TFCC attach the distal ulna to the hand and the ulna to the radius. The interosseous membrane spans the length of the forearm, and it contributes to the longitudinal stability of the forearm. Proximally, the interosseous membrane has 2 components, the proximal oblique cord, as well as the dorsal oblique accessory cord. And then the middle portion of the interosseous membrane contains the central band and the accessory band. The central band is the most dominant and consistent structure of the interosseous membrane. And histologically, it actually appears very similar to tendon in terms of its collagen arrangement. And the accessory band has many anatomic variations, but it largely runs parallel to the central band. In addition to understanding the bony and soft tissue anatomy, it's crucial to understand the deforming muscular forces in both bone forearm fractures. The supinator, pronator teres, and pronator quadratus insert along the proximal, middle, and distal third of the radius, respectively. So in fractures that are proximal to the pronator teres, you'll see flexion and supination from the unopposed action of the supinator and the biceps. However, in fractures that are distal to the pronator teres, you'll see pronation and ulnar deviation along the distal fragment. Appropriate interpretation of radiographs is critical to assess intraoperative reduction and for the execution of osteotomies. So I'll briefly discuss some important concepts. During workup, you can obtain PA as well as lateral radiographs in a neutral rotation. And then you can also obtain max pronation and supination films. And contralateral films are helpful to not only understand what's normal, but also for preoperative planning. Shemich described the importance of restoring the magnitude and location of the radial bow. To measure the magnitude and location of the radial bow, you obtain an AP in neutral rotation, and then you draw a line from the midpoint of the bicipital tuberosity to the ulnermost aspect of the distal radius, and this forms your baseline Y. And then a perpendicular line is drawn from the baseline to the point of maximum radial bow, and this represents the magnitude. And then the distance from the bicipital tuberosity to this intersection represents the location of bow as a percentage of the baseline. Rouleau et al. Previously described the proximal ulna dorsal angulation, or the PUDA angle. And this is determined by measuring the intersection angle between the tangent lines on the formed between the flat spot of the olecranon as well as the dorsal ridge of the ulnar shaft. The average PUDA angle is 5.7 degrees, and it's especially important in Montesia fracture dislocations, as failure to restore this angle can result in persistent radial head dislocation. Rotational deformities are more difficult to assess. Many orthopedic surgeons assess rotation and quality of the reduction using a technique that was described by Evans, where the bicipital tuberosity and the radial styloid are said to be oriented 180 degrees axially apart on a PA or an AP radiograph. Similarly, other surgeons use the coronoid process and the ulnar styloid, which are also said to be 180 degrees apart. This radiographic analysis was further studied by Weinberg et al. In 2016. This was a cadaver study with 600 forearms, and they took axial photographs of the proximal and distal ends of the forearm, and then used those photos to assess the rotation angle between the landmarks. And overall, they found that the radial styloid was at a mean of 158 degrees of supination relative to the bicipital tuberosity, while the ulnar styloid was at a mean of 185 degrees of supination relative to the coronoid process. Now that we've reviewed some anatomy and radiographic analysis, I'll dive into malunions. Forearm malunions have a significant impact on forearm rotation, and this is especially important because previous studies have found that the majority of activities of daily living require 50 degrees of both pronation and supination. And the impact of the deformity is dependent on multiple factors, including the location of the deformity, whether it involves the radius and or the ulna, the degree of the deformity, and the location of the deformity in terms of proximal to distal, the type of deformity and length. And now I'll discuss some landmark papers that helped us understand how forearm malunions can affect range of motion. So how does angular malalignment affect rotation? This was studied by Matthews et al. In 1982. And this was a cadaver study with 10 cadavers, and they assessed range of motion after creating 10 or 20 degrees of angular malalignment in the sagittal and the coronal plane in the middle third of the forearm. The results are summarized in this table. So these represent degrees of pronation and supination. And overall, there was a significant decrease in pronation and supination with 20 degrees of angulation in the radius and or the ulna in all directions. So that includes dorsal and volar angulation, as well as angulation towards the interosseous membrane. However, with 10 degrees of angular deformity, the pronation and supination was in the normal range for all groups. And then these studies were reinforced by Tar and Sarmiento et al. In the 80s and 90s. The location of the deformity in terms of proximal versus distal also makes a difference. So while previous studies showed that 10 degrees of angulation was acceptable along the middle third of the forearm, this is not true with proximal deformity. And this was exemplified in a study by Snow et al. From 2014. In this cadaver study, they produced varus and valgus osteotomies with 5, 10, and 15 degrees of angular deformity along the proximal third of the ulna. And then overall, they found that varus or valgus deformity of 10 degrees resulted in a significant loss of forearm rotation. Specifically, in varus deformity, there was a subsequent loss of forearm pronation without any change in supination. And then in valgus deformity, there was more loss of supination, but also some loss of forearm pronation. And then how does rotational deformity impact range of motion? In 2003, Kasten et al. Performed a study with cadavers where they looked at how rotation affects range of motion along the middle third of the radial shaft. And they found that supination torsional deformities of more than 30 degrees caused significant impairment with pronation, while supination was not impaired. And then similarly, a significant amount of supination deficit was found at pronation torsional deformity that was more than 30 degrees. So you can summarize this by saying, for rotational deformities of the midshaft radius, you lose motion in the opposite direction of the rotational deformity. And then in 2000, Tynan et al. Did a study where they looked at rotational malunions of the ulna, and overall they found a similar trend. So they performed midshaft ulnar osteotomies in 6 cadaver forearms. And overall, with an increasing amount of pronation, they found that there was more pronation range of motion with a corresponding decrease in supination. And then conversely, with increasing ulnar supination malunion, there was a progressive decrease in pronation and a progressive increase in supination. While there were similar trends, it appears that the ulnar rotational malunion appears to have a greater, a less of an impact on pronation, supination range of motion compared with radial shaft rotational malunion. And then loss of length also impacts range of motion. This was a study out of the University of Washington in 2022. There were 8 cadavers in this study, and they performed a transverse osteotomy at the radius and ulna at the junction of the middle and the distal third of the forearm. And then they proceeded to perform 2, 4, and 6 centimeter shortening osteotomies, which were then stabilized with a 3-5 LC-DC plate. And overall, that they found shortening was associated with progressive reduction in range of motion. Bony impingement is thought to be a large component of decreased range of motion in malunions, and this was further studied by Abe et al. In 2018 in JBJS. The authors looked at 18 patients with forearm malunions and limitations in their rotational forearm range of motion. And then they created 3D models to quantify deformity and to analyze bony impingement. So 3D motion of the radius relative to the ulna was measured by superimposing the ulna in maximum supination and pronation on the ulna in neutral rotation. And then they calculated the shortest distance between the radius and the ulna, and they defined impingement as a distance of less than 1.5 millimeters between the radius and ulna. Of the patients that were included in the study, 16 of the 18 had an extension deformity of the radius and a valgus deformity of the ulna. And overall, they found that there was a significant negative correlation with pronation range of motion and supination range of motion. And of the 16 patients, 15 had evidence of bony impingement in a position of pronation. They also looked at central band tightness and to see if that could affect range of motion. And in this model, they used anatomic data to create 3D models with a polygon mesh along the area of the interosseous membrane. And then they calculated the central band tightness by the rate of length change in the central band. And so this graph demonstrates the average CB length ratio, or the CBLR, for the normal and the affected side. And overall, the average CBLR of the affected side in supination was significantly larger than that in pronation. And so this indicates that while bony impingement may be a greater limiting factor to motion in pronation, that it's possible that central band tightness may be a limiting factor in supination. Now I'll segue into a discussion of operative management of forearm malunions. Traditionally, preoperative planning for forearm malunions involved obtaining full-length plain films of both forearms, and then outlining the normal and the deformed bones on separate sheets of tracing paper. And then by superimposing the images, the surgeon is able to determine the location of maximal deformity and angular deformity in both planes. Recently, however, there have been significant advancements in technology with 3D planning, software, as well as custom jigs that Dr. Huang will be discussing in a minute. But first, focusing a bit on the traditional methods, the deformity of the frontal plane and the sagittal plane can be assessed using PA and lateral films. And then established tables factor in the deformity of the frontal and the sagittal plane to assess the true angle of deformity. And this angle defines the angle required for a closing wedge osteotomy or for structural bone graft for an open wedge osteotomy. And then correction is performed in the plane of maximal deformity. And then intraoperatively, K-wires can be used as landmarks, as well as to help with the osteotomy, as depicted by these solid and dashed lines. There are different types of osteotomies, and different osteotomies assess or address different types of malunion. For example, transverse osteotomy is used to address rotational or translational malalignment, and then angular deformities can be treated with oblique, opening, or closing wedge osteotomies. An opening wedge osteotomy can be used if the angulation of the deformity is more acute, while an oblique osteotomy can be used when there is a more gradual deformity. So how do patients do after corrective osteotomy? Previous studies have found that corrective osteotomy can improve patient range of motion. For example, Nagy et al. Looked at 17 patients with symptomatic malunion after pediatric forearm fracture. And the patients were then divided into 3 groups. So group 1 had 6 patients with a loss of pronation. Group 2 had 4 patients with a loss of supination. And then group 3 had 7 patients with a painful or unstable DRUJ. And then they performed corrective osteotomy according to the type of malunion that they had on radiographic analysis. And overall, they found that the patients in group 1 gained 38 degrees of pronation, but lost 6 degrees of supination. And then patients in group 2 gained 80 degrees of supination, but lost 11 degrees of pronation. And all of the patients in group 3 had improvements in their pain and stability along their DRUJ. And they didn't find any significant difference in the dash scores or grip strength between the different groups. Other studies have also found improvements in the range of motion, DRUJ, and dash scores. For example, in a 2011 study by Chia et al., they looked at 6 patients who had symptomatic malunion who underwent either a closing wedge osteotomy or an oblique osteotomy to address their malunion. And overall, patients had a median improvement of 48 degrees of rotation. Interestingly, In both this study and the study by Nagy et al., it appears as though patients who undergo corrective osteotomy have a relatively larger increase in their supination range of motion compared to their pronation range of motion. The timeline of corrective osteotomy may be important. In 1995, Truesdale et al. Performed a retrospective study on 27 patients who underwent corrective osteotomy for forearm malunion. Of those 27 patients, 20 had a loss of functional forearm rotation and 6 had a painful or unstable DRUJ. And then within the 20 who underwent osteotomy for loss of rotation, 9 were operated on within 12 months from injury, and 11 were operated on more than 12 months out. And the patient who underwent early osteotomy had a significantly more improvement in their range of motion compared to the patients who underwent late osteotomy. And then similar results were found by Van Gienen et al. In JBJS in 2007. Specifically, they looked at 20 pediatric patients who had sustained forearm fractures before the age of 16, who then went on to symptomatic malunion and underwent osteotomy. The average age of patients in this group was 12, and then on average, patients were 30 months out from injury. But overall, they found that there was greater improvement in range of motion in corrective osteotomy that was performed in patients who were less than 10 years old and who were less than 1 year out from their injury. So in summary, forearm fractures are common in children and less common in adults. And malunion is a known complication that can result in loss of rotation and a painful or unstable DRUJ. And then angulation up to 10 degrees is generally well tolerated. And then corrective osteotomy can improve range of motion as well as DRUJ instability. And that the timeline of corrective osteotomy may impact patient outcomes. Thank you. And here are my references.
All right. Thank you, Elle, for the outstanding talk on forearm malunions. I'm going to transition right now to my portion of the talk. All right, good morning, everybody. I want to really thank Elle for inviting me to be part of her Grand Rounds talk on forearm malunion, looking at old school versus new school. These are my disclosures. So again, I really want to thank Elle for her outstanding talk, looking at forearm malunions, looking at the background, relevant anatomy, radiographic assessment, biomechanical studies, and really looking at clinical outcomes for both adult and pediatric malunions. And from there, I'm going to transition looking at 3D custom guides. Is there really a role for 3D guides, and how much better are they compared to conventional osteotomy? And also look at a couple cases. So I remember going to AO course when I was a resident, going way back, kind of dating myself here, carrying large X-ray jackets, the tracing paper. We had plastic templates of all the different implants that are out there, and really carefully planning out the osteotomy or performing fixation of a complex fracture. I think it's really become a lost art. I'm going to show a couple cases of Dr. Bure that he shared with me. This is an 83-year-old with a history of substroke fracture 15 years ago with very severe varus collapse over the femoral neck and substroke region, who came with a limp and a leg-like discrepancy. This is what we used to do. This is probably about 15, 20 years ago. Get tracing paper of both the injured side and the contralateral side. Really figure out how much deformity you have, how much angular deformity, how much of a defect do you have. Cut that defect out. And the goal is to try and match it to the contralateral side. For the residents who are part of the conference call, you can see just the amount of meticulous planning, really knowing the anatomy really well, knowing your implants, and really a step-by-step kind of a recipe and algorithm for treating the malunion, including taking out the hardware, performing your osteotomy, which part of the cortex should be intact, how much of correction are you getting, also where the hardware is placed, also trying to figure out the overall alignment and placement of the hardware as well. This is the final radiographs post-reduction by Dr. Bure. If you compare that with initial planning and tracing paper, really impressive as far as the amount of planning and execution to really achieve a near anatomic correction of the femoral neck and the proximal femur. Another example shown here, again, a very severe valgus proximal tibial malalignment with collapse of the tibial plateau that was fixated previously. Again, looking at the injured side versus the contralateral side, the amount of correction needed, kind of goniometer measurements. Again, this is all done via computer now, and a lot of advanced imaging we have nowadays. But back then, is really trying to get a tracing paper out, a goniometer, and trying to figure out how much of a closing wedge needs to be performed versus an opening wedge osteotomy. And this is the final correction on this patient, both pre and post. Look at how much correction you're trying to achieve. In middle panel, you can see amount of valgus proximal tibial malalignment compared to final radiographs, where the injured side and the uninjured side match up perfectly as far as correcting overall biomechanical axis of the femur and tibia going down to the ankle. So we know technology has really changed what we do. My kids no longer really study via normal textbooks. It's iPads, computer, and laptops. The amount of video platforms nowadays and AI is really impressive as far as learning. I think our residents are learning via electronic textbooks, surgical videos, and even simulators to really let them kind of in real time see what's going on. Remember the days of a playground where you see kids running around outside and doing their exercises, doing physical fitness exercise in PE classes, now replaced by indoor gym with a Nintendo Wii with a large screen TV. And I think it's really changed what we do. And the question becomes, is new school really better than old school? What are some of the advantages? There's been really explosion of interest in technology and AI, specifically ChatGPT. My kids are currently in middle school, and ChatGPT can essentially not just answer really complex questions for you, but could write an entire research paper, a research report, could plan an entire curriculum for you, and really also provide tutoring. So really fairly powerful technology. And actually a recent study looking at ChatGPT, even taking the OITE. So ChatGPT version 3 could actually take an OITE exam and score approximately 54%, which is knowledge base of a PGY 1. The newer and better ChatGPT 4 actually scores 76%. So really AI is not really good at simulating the facts and knowledge, but also interpretation, assessment, and really analysis of the information given to it. Computer navigation with the Mako's knee certainly made total knee arthroplasty in many ways much more accurate and much more reproducible. There's actually a couple of forums recently talking about ChatGPT. Is it potentially better than a hip surgeon as far as not just planning, but execution of a total hip arthroplasty? Preoperative planning used to be the old school way. Example, Dr. Bure really just kind of map out the injured side, the malunion side, doing a mirror image of the contralateral side, really meticulous planning of not just the location of the osteotomy, amount of correction, magnitude of correction, but also where your hardware needs to go. Nowadays, for the faculty to use some of the custom jigs and custom cutting guides out there, it's really truly preoperative planning that comes in a box. All the cutting guides are made for you. The sawbones are given to you on the injured side, the contralateral side, and you kind of follow a recipe book, kind of step 1 through 20 on performing the osteotomy and fixation as well. Certainly, explosion publication increased in interest and number of papers looking at the role of 3D printing, both the concept of it, feasibility, and also clinical outcomes looking at corrective osteotomy using 3D cutting guides, and perhaps it can lead to a better outcome overall. Should we really do a 3D custom guide for every case? I think it really comes down to how good is your carpentry. I think we certainly have a phenomenal trauma faculty. I think the planning, the execution has to be perfect for you to have a good outcome. It's something that you're used to doing and kind of doing everything freehand, whether it's tracing paper or freehanding it. Knowing the anatomy, knowing the implants are out there certainly can be helpful. But I think it's really kind of knowing your skill, knowing your limits, and also kind of how you're trained as well. I think in the upper extremity world, as a hand surgeon, I feel that we're pretty good at performing a simple uniplanar osteotomy. I think a standard dorsally angulated distal radius malunion with the anatomic volar plate, we could make our osteotomy parallel to the joint line, and then use a volar locking plate and do an opening wedge osteotomy with bone grafting dorsally. I feel like it do pretty well. This is a case I just did about 3 weeks ago, a patient who had both a distal radius fracture and a implant radial forearm fracture that was fixated elsewhere in different stages, who actually ended up with another fracture just distal to the LCDC plate. In this case, we felt like we could do this freehand as well. So we placed K-wires perpendicular to the long axis, the radial shaft, both distally and proximally, and really utilized an anatomic plate to restore the alignment on this particular distal radius periprosthetic fracture. I feel like certainly a lot tougher to do without a custom guide, but certainly doable with some of the cost savings by doing this freehand and using guides that are available to us. But how good are we? I know we could kind of eyeball it, use the anatomic volar plate, especially for distal radius malunion. There are a couple of studies looking at corrective osteotomy of distal radius malunions. It turns out about 1/3 of the time, we're actually off by about 10 degrees or more as far as angulation. And about 1/3 of the time, again, we're off by our length by about 2 millimeters. So as much as we could do this freehand, try and make it as perfect as possible, I think for the most part, we do fall short. Computer simulation certainly makes it a lot easier. This is a study out of Japan by Miyake et al. Again, using an anatomic distal radius plate, custom guide as far as doing your drilling ahead of time, your distal locking holes, as well as your proximal drill hole for the radial shaft, and then using your osteotomy through the guide to perform an opening wedge osteotomy. And afterwards, you can see the pre and post reduction, really taking advantage of the anatomic plates and doing the pre-drilling ahead of time makes reduction not just easier, but much more accurate and much more reproducible. Do we have to do 3D printing? Is it really that much better? Can we really justify the cost? This is a multi-center study by Bugis out of the Netherlands, looking at doing 3D versus 2D, a multi-center study, where they found that while the correction was slightly better compared to a traditional 2D planning, overall, really a minimal improvement in range of motion and promise score. So the authors concluded that although it is feasible to perform the osteotomy with the 3D printed guide, perhaps it's slightly better. It is a lot more expensive, or at least at this time, it's probably not justified for every distal radius malunion. So let's look at a couple of cases and looking at applying some of the concepts that Elle had talked about earlier. This is a patient that presented to me about 10 years ago who came to me. The chief complaint was DRAJ dislocation or instability. See, this patient is about 10 millimeters ulnar positive with dorsal dislocation of the DREJ. Turns out that the malunion was the result of inadequate hardware. Patient had a recon plate placed for both the radius and the ulnar shaft, which resulted with a very severe deformity of the radial shaft with fairly severe apex volar angulation. This case felt like really a uniplanar osteotomy had to be performed. So by doing a corrective osteotomy and restoring the overall height, also make sure the radial bow was restored. We compared to the contralateral side. So like overall had a fairly good restoration of overall anatomy. Really rely on the fact that the radial shaft is quite flat volarly. So that's how we really lined up the overall rotational alignment of the radial shaft. But I would argue if you look at the AP on the left, there is some residual malrotation. Radial styloid does not match up with bicipital tuberosity, but overall, in fact, the correction was certainly adequate. The patient did have a stable DREJ. As Elle alluded to, I think majority of these patients, especially the ones with DREJ instability, are the ones that probably benefit the most from a corrective osteotomy to restore not just form range of motion, but restore a stable DREJ. What about this case here? This is a 52-year-old. Again, this case was performed fairly recently, so a fairly timely topic. Had a both bone forearm fracture that was open, fixated outside hospital, presented with pain, very limited pronation to 10 degrees compared to 80 on the contralateral side, supination 70 compared to 40. And again, a very painful DREJ that was grossly unstable. Hardware failure, apex volar angulation. We'll find that majority of these have an extension deformity at the radial shaft. Patient was also quite short, 4 millimeter ulnar positive. The question becomes, you have a well-healed ulna, but a distal radius that's gone on to a malunion/non-union. Do we do a radial osteotomy and do an opening wedge osteotomy, or do we do both a closing wedge and also a shortening osteotomy on the ulna to line up the overall length? And does this have to be 2D versus 3D? So in this case, we chose to do a closing wedge osteotomy on the radius and shorten the ulna, so we achieved nearly neutral ulnar variance. Still a little bit of DRAJ widening, as shown the AP there, but overall DRAJ was quite stable. And we assessed forearm pronation supination intraoperatively to make sure that we had restoration of both pronation and supination passively. Some of the radiographic parameters that Elle had alluded to, looking at rotation, if you look at the radial stylo compared to tuberosity, it's almost 180 degrees. So it felt like overall, we were able to restore the angular malalignment as well as rotational malalignment of the radius and ulna. Proven range of motion even at 6 weeks post-op. Pronation improved to 40 degrees even at 6 weeks. Supination went from 40 to 60, but probably just as important, the DRAJ felt quite stable clinically at 6 weeks post-op. The problem, though, is majority of these are not uniplanar deformities. Miyake looked at a series of 20 patients and did 3D analysis of a both forearm fracture. Found the majority of patients had really a 3D multiplanar deformity. In this case series, average extension deformity of 18 degrees, valgus angulation of 2 degrees, and also rotational component of 16 degrees of pronation deformity as well, across the radius or ulna. So based on this kind of initial analysis, they performed a kind of case series looking at feasibility of doing computer-assisted corrective osteotomy. I think this is really the early iteration of 3D planning and the custom guides as well. You have 3D planning cutting guides that are placed on the radius and ulna that are fixated with K-wires with cutting slots. In this case, we're doing a closing wedge osteotomy on the radius and ulna. And as you place the K-wires parallel to each other with the reduction block, really allows you to perform a near anatomic reduction of the radius and ulna with the closing wedge osteotomy. Another study looking at 3D versus 2D, is it really better? Elle talked about different types of osteotomies that can be performed. This case series looked at really 3 types: a opening wedge osteotomy on the distal radius, a closing wedge osteotomy on a radial shaft malunion, or more of a single cut sliding osteotomy for somebody with both a rotational and angular deformity of the radial shaft, where you try to correct both of them at the same time. And on the right, just intraoperative photos showing what the cutting guides look like and what the K-wires look like, both pre-correction and post-correction. The goal is to have the K-wires parallel to each other when you're done with the osteotomy. What they found was that certainly with the 3D cutting group, healing was much faster, presumably because he had a better reduction and better bony apposition. 61 versus 32% were healed at 12 weeks. OR time is a lot faster, 140 versus 108 minutes. So by doing a 3D cutting guide, I think a lot less kind of fiddle factor intraoperatively makes it a lot easier. Long-term outcomes are fairly similar. Range of motion, grip strength are pretty similar outcome. I think part of the key point of this paper also is that as long as your correction is done well and near anatomic, I think their functional outcomes are quite similar, but you may have just slightly faster OR time. And also a couple of studies have also shown that the EBL is much less with 3D planning. Study out of Belgium, I think if you look at the literature, I think certainly the European, the Japanese literature is way ahead of the US literature looking at 3D planning guides in osteotomy. This is a pilot study by Bern et al. Out of Belgium looking at 5 cases. In this case series, you'll note that it's not just a cutting guide, but there are also drilling guides for both the radius and ulna. So you're pre-drilling your holes both proximally and distally in the radial shaft and ulnar shaft, and then using your custom cutting guide and doing the correction ahead of time. Pilot 5 cases and really impressive correction. The preoperative angulation varied from about -20 to 23 degrees on the lateral and -13 to 20 degrees on the AP. And if you look at their final correction, they were within 1 or 2 degrees of angulation for both the radius and ulna. And as expected, by doing a near anatomic reduction of the radius and ulna, they were able to restore wrist flexion extension, also forearm pronation supination, nearly equal to the contralateral side, and certainly a significant improvement compared to the preoperative range of motion. And also shown in this case series, as shown by Dr. Bui earlier, if you look at the improvement in pronation was 80 to 97 degrees, and supination 53 to 95 degrees. So certainly a nearly 40-degree improvement in forearm supination. So now we're going to kind of go from simple to more complex for the pediatric faculty on the phone call here. This is a 15-year-old male who had a Salter 2 distal radius fracture about 2 years ago at age 13. That was appropriately treated with cast immobilization. And patient came in to an outside hospital, 1-year history of DRAJ instability. Again, this is likely the most common complaint that patient will come in with. Popping and dorsal subluxation of the DRAJ with activities. This is a pretty active kid who enjoys sports and just kind of having fun with his friends. And initial plan was for a corrective osteotomy, just a 2D, a traditional osteotomy performed by another surgeon. Unfortunately, after the initial appointment, patient came in 3 days later with a new injury to left forearm. Again, just kind of horsing around with his friends, and had a proximal radial shaft fracture. And initial recommendation was non-operative management with a long-arm cast. And patient came to me 2 weeks later for a second opinion. So we kind of discussed, what do we do with this proximal radial shaft fracture? On the AP, looks like alignment looks quite good. If you look at the lateral though, there's certainly a component of perhaps plastic deformity of the proximal radial shaft. So really the question becomes, what do we do with the proximal radial shaft fracture? And what's the best timing now for just a 1/3 radial shaft malunion? At the time, the patient and family chose non-operative management for the acute fracture. This is looking at the injured side compared to the contralateral side. And really, as you look at this, deformity is certainly a lot more complex in the first two cases. Should we be doing a 2D planning versus 3D planning for this particular patient? I think if I looked at kind of a rudimentary look at this, kind of a pretty simple way of looking at this, apex volar angulation at the distal 1/3 of the radial shaft. So I'd be looking at a corrective osteotomy, as shown in the picture on the right. There's certainly a malrotation component to the radius. You look at the radial styloid, and the tuberosity doesn't match up perfectly. And also, what do we do with the proximal radius? Do we do that at the same time? And at least looking at it really kind of quickly, the ulna looks pretty normal overall. But we decided to get 3D planning. We got CT scans of both the injured side and the contralateral side, and got a sawbone 3D model of both sides. If you look at a computer superimposed mirror image, you'll find that the ulna is actually malrotated. It's really more of a rotational malalignment. And the radius is actually fairly severe angulation, both proximally and distally, as shown in the middle in the right panel there. Really severe angulation, volar and dorsal, both proximally and distally. So in this case, I felt like with really a triple deformity, a triple osteotomy, this is best done through doing 3D computer simulation. So based on, this is sent to a commercial company in a planned closing wedge osteotomy proximally, combined with a opening wedge osteotomy distally, and a closing wedge derotation osteotomy in the ulnar shaft to try and correct the rotational malalignment. The goal is trying to restore the alignment, not just angular alignment, but try and minimize shortening of the injured forearm. 3D cutting guide certainly makes this much easier. If you look at the cutting guides on the left, you can see for the ulna, you're looking at a fairly significant derotational osteotomy on the ulnar shaft and a fairly small closing wedge osteotomy. And looking on the right, you're looking at custom drill holes that were created both proximally and distally to fit a metadiaplate. And a closing wedge osteotomy is going to be performed proximally and opening wedge distally. This is the design and the planned correction and planned fixation of the radial shaft, as well as the ulnar shaft on the left and right. Intraoperatively, starting with the ulna, we kind of used the sawbone to figure out exactly placement. For the faculty and the residents who haven't done this, what makes it really tricky is trying to place the cutting guide and the drill guide perfectly along the ulnar shaft, really counting on the contours of the ulnar shaft to really slide that cutting guide and drill guide proximally and distally. So I actually used a sawbone to figure out where I needed to be approximately and distally. The holes are pre-drilled, followed by placement of a cutting guide. This case, the cutting guide is placed with K-wire is put in place, and you can see from the intraoperative photos, really impressive as far as how accurate the corrective osteotomy is in the pre-drilling of the holes, both proximally and distally, with good bony apposition and good compression across their closing wedge osteotomy. This is a patient at 2 weeks post-op, coronal sagittal alignment nicely corrected the height overall, and at his 2-week post-op appointment, the DRG felt fairly stable, both dorsally and volarly as well. And certainly explosion technology for 3D printing for hand surgery. We looked at the custom drill bits, the custom cutting guides, certainly makes it a lot easier. Nowadays, 3D printing is done with additive printing. So you could print really any material. It could be plastic, it could be any metal alloy, including titanium, stainless steel, and cobalt chrome for total joint replacement. Custom cutting guides, custom plates, and custom implants are becoming more and more popular. Certainly talking about the tumor guides, this is a really standard practice for some of the patients with really severe deformities involving the articular surface. So going from complex to even more complex, to present case number 4, the final case I'll be presenting, a 36-year-old male with a history of RIF of the right proximal radius ulnar fracture that was fixated in Nigeria 15 years ago following the MVA. Patient came at elbow range of motion 30 to 120, pronation 0, supination 60. A really very impressive deformity of the proximal ulnar radius with a non-union, big gap on there. You can see preoperative patient had a very severe varus deformity and flexion deformity of the proximal ulna. Preoperative CT scan just showing amount of deformity and also amount of gap across the proximal ulna non-union. This is where I think the 3D cutting guides and planning is really powerful. Mirror image of the injured side compared to the contralateral side as far as how much correction do I need to try and achieve, but also trying to really determine ahead of time how big is my defect across the proximal ulna. And I think the custom drill guides certainly makes this surgery much, much easier. The custom drill guides are placed both proximally and distally on the ulnar shaft with the cutting guides for both the proximal and distal resection. And these are really predetermined based on the implant I chose for this particular case. The holes for drill guides matched up perfectly for the holes for the pre-selected plate. So you have pre-drilling, and once the drilling is done, the cutting guide is placed, and you make your custom cuts on this. Now you can use a plate as your template to try to reduce the proximal ulna to the distal ulnar shaft. It makes this case really unique because not only does it help with my custom guides as far as drilling and cutting, but also creating a custom wedge for this particular case. This case, I had the choice of just a custom wedge that fit the defect perfectly as far as size and contour, but also if I'm worried about instability from lack of a corner and trying to create anterior buttress, that was an option given as well, as I could actually recreate part of the coronary process with the custom cage. This is a patient at 6 months post-op. So in summary, Dr. Bui nicely outlined that excellent outcomes can be expected with a corrective osteotomy with a forearm malunion. I think 3D custom guides really makes it much easier, more accurate osteotomy, a better reduction, and shorter OR times. I think certainly in 2023, I think you don't have to use a 3D guide for every osteotomy. The cost is certainly very prohibitive. You're looking at bilateral CT scans, which are about on the order of $2,000 to $3,000. Increased radiation. The custom guides are about $5,000. I think really the future is really having hospitals own their own software, 3D printer as well, having our in-house engineers do this on a more cost-effective basis, and also cheaper printers and material as well. And with that, thank you for joining us.
Dr. Huang, Dr. Bui, thank you very much for that excellent Grand Rounds talk. Very exciting stuff. We're talking about new technology. Does anybody have any questions out there? Please feel free to speak up or put your questions in the chat. I can start us off though. Jerry, in your experience with these guides, like what, I mean, obviously, you know, these things look like kind of plug and play. That seems to be some of the draw, and I can definitely see the advantage when you have these multiplanar, especially rotation and angulation corrections. What do you think is what have you found in terms of like, what's the worst thing that could happen, and what are the bailouts kind of if the, if the guy just like you make a cut and it's incorrect? I mean, then you just have to kind of fall back on conventional techniques, or what have you found is some of the big downsides of this? Like,
Yeah, I think it's certainly a great question. I think there's certainly the temptation, plug and play. You put the guides on there, you drill, you cut, you do reduction according to the drill holes and assume that's going to be correct. I think there's certainly a component of preoperative planning. With each of these cases, I jump on a call with engineers and really make sure I understand where the contour needs to be, the morphology of the bone, if it's going to fit correctly. They actually give you the saw bones ahead of time. So if you wanted to, you can get additional saw bones and do the practice cuts ahead of time. If you don't trust the computer simulation, you can actually do it yourself, all the saw bones ahead of time. I think if you look at some of the early papers by Jupiter, they actually recommended doing these before 3D technology, is actually trying to get the 3D prints of the fractures and the malunions to try and do it preoperatively. Even the case I showed is a pediatric patient that was actually delayed by a few weeks. So just in that few week delay, the guides actually didn't fit perfectly. So we actually had to do a little bit of freehand, especially on distal osteotomy. The contour was off by just a little bit. So some of the techniques of as far as reduction and also contouring the plate, I think is still really important. It requires contouring of not just a reduction, but also plate as well. So I think it's really a big part of it.
yeah, I can imagine. You have to be pretty experienced with osteotomy to begin with. I think it's not just anybody can approach this just because you get the guides.
Yeah, I think it's like anatomic plates for any fractures we fix. I think it's pretty easy to kind of fall in the trap of using the plate to reduce everything for you. But I think you really have to understand really the anatomy quite well, radiographic parameters as well, as far as what's considered normal. Let's have a
Dr.
question.
Black
by
had a
Roberts.
question, I think, for Dr. Bui here. In the chat, the majority of the literature on association of deformity with loss of motion appears to be in cadaveric studies. What's the best clinical data that you've seen?
So most of the studies that I came across, the patients already had a complaint of the, this is the one by Dr. Scott Yang.
Oh, sorry. I think Dr. Lack just sent it to me. He was asking, the majority of literature on the association of deformity with loss of motion appears to be in cadaveric studies, but is there anything from clinical data to support that or contradict that?
I see. Yeah. Most of the studies about like range of motion seem to be cadaver studies. I think it's harder to study in patients because the patients that are showing up are the patients that have symptoms related to their malunion. And so I didn't personally come across many studies where it was like malunions with subclinical range of motion deficits. I think most of the patients tended to be more symptomatic.
Yeah, I asked that question just to confirm. You presented the literature really well. I just find it interesting because it's a common pediatric problem, both bone forearm fractures, and so you'd have to do a prospective observational study, and it's kind of striking to me that it doesn't that there isn't one, because it's not necessarily easy to do, but it's common enough that you could do it. It just seems like there should be at least one, but I haven't seen a good one either. So I wasn't looking for more necessarily, but making sure I wasn't missing anything. So thanks.
And then, as you mentioned, I think it is, I guess, rare enough that some of the studies, even if they were to find enough patients, it would be pretty underpowered, I think.
Yeah, I think the key of some of the papers that Dr. Bui presented is really looking at their preoperative complaint. I think really addressing patients that are truly symptomatic. I think to Will's point, a lot of patients with the angular deformity actually do quite well. They're well tolerated, even up to 20 degrees for biomechanical studies, clinically, maybe even more. But as long as they're doing quite well as far as rotation and DRG stability, I think most of these can be treated with benign neglect and do pretty well.
Yeah, and I in no way mean that we should be not treating these aggressively when there's symptoms, or that I just find it interesting that I've treated these before as pediatric patients and some adult patients now, and although it's not as common, and I just find it interesting that that data is kind of, that observational data is missing. But I really enjoyed your guys' talk.
Yeah. There's it looks like Dr. Roberts
Yeah.
now has a question.
You mentioned briefly how timing affects things, right? Where you had a patient sort of change while the design was in process. Obviously, timing is something that is relevant to our custom work in tumor. So I was wondering, overall, what is the average time course for a case like this between sort of identifying the patient, initiating the design process, working through the design process with the engineers, getting them to a delivered product? And I would imagine each of these is requiring FDA compassionate use approval. What is the average time for all of that for you?
Yeah, that's a great question. I think the companies are getting faster and faster. So for pediatric forearm fractures, the FDA actually has a stipulation. It has to be done within 4 weeks of your CT scan. So, and the companies know this. So the turnaround time is actually 2 weeks for this. So once you have the patient that you're planning to do the case for, you get your CT scans, they generally will hop on a call with you within a week of your CT scan be delivered to them. And they actually have the custom guides sent to you within 2 weeks. Because beyond 4 weeks, it's actually not recommended. They actually recommend getting a repeat CT scan. So I've worked with 3 different companies, and generally the turnaround time is about 3 weeks or so. That's for a custom cutting guide and also drill guides as well. But if you're looking at an implant, so whether it's a cage or they do actually tailor replacements, entire partial articulate implants, the turnaround time is about 6 weeks for those. So kind of definitely something to keep in mind as far as looking at preoperative planning and scheduling for these patients. I think more complex 6 weeks. The simple ones we're looking at about 3 weeks right now.
Sounds good. And each one of them does require compassionate use FDA approval, right?
They do.
What requires compassionate use?
We're doing the custom cutting guides. It at least through what I've done through UW actually requires a compassionate use approval through the UW compliance office.
Oh, I didn't even realize that. So, but when we use materialize, we don't have to do that, do we?
The last case actually did require a whole entire process as well, Steve. I don't remember. I've done 3 cases the last year, and I think each of them actually did require some type of approval process, independent of just the hospital committee approving this.
Yeah. Okay. One question that I had was about, I was interested about the cages. So, one issue that we have sometimes is segmental non-union. Have you used any, or are you aware of any, custom cages for like long segment defects that you could potentially pack, bone graft into?
Yeah. So certainly the one example I showed is actually a custom porous cage that's designed by a company based out of the East Coast. It's actually designed specifically for non-union defects. So much more popular for the ankle world. They've done huge defects in the tibia. And I know Dr. Mark Rich out of Duke has done this for ulnar non-unions as well. So it's almost like the cannula implants that they use for acetabular reconstructions. The amount of bony on growth and ingrowth is actually pretty impressive. So the goal is to create a custom implant to fit the defect and also put cancellous bone graft in between. And they've shown pretty impressive results clinically.
Cool. Thanks.
Reza had his hand raised. Reza, are you still on the line? Dr. Ferguson?
Yeah, Jerry, great talk. Very informative. In some of these chronic malunions, is there, soft tissue constraints that you worry about? It might be easy to, know what osteotomies to make, but have you come across cases where the planned osteotomies are so great that, there's really significant soft tissue constraints that, you have to consider and make releases as appropriate?
Yeah, definitely. I think there are a couple of clinical studies showing that, at least in the forearm, sometimes you do have to release the interosseous membrane pretty aggressively. I think Elle really nicely talked about the kind of biomechanics of central band and its role, but I think in some cases do have to kind of strip it quite a bit. And the case number 4 I showed there, that reduction, even with a custom drill guide and custom cutting, trying to get that reduction was actually kind of a bear. It was really kind of a lot of
Yeah.
soft tissue restraints trying to get that reduced. So I almost had to strip that completely and devascularize the bone just to get that reduction achieved. So, and it's a great question. Some of these, it's quite tough to try and get the reduction.
Thanks.
Everything would be easy if everything could be done in sawbones land with no soft tissues and nerves in the way, wouldn't it?
I know. I think if you do these with the engineer, it's also important to point out to them that we're not doing a sawbone, so the exposure is not as easy as a sawbone. So they kind of forget that part of it as far as where the K-wires go. And some of the cutting guides, they kind of forget that there is a soft tissue component we have to try and work around and dance around.
Well, Dr. Huang, Dr. Bui, thank you so much. That was very informative. Great grand rounds. And thank you everybody for attending.
All right. Thank you, everybody.
We'll see you next month. Thank you, everyone. Have a good day.